Let me introduce myself. I'm Bill O'Leary. I am the Senior Director of Policy for Microsoft Health and Life Sciences. We're going to be talking today about privacy and security. It's a real pleasure on this panel to have Leon Rodriguez, the Director of the Office of Civil Rights for the country, as well as Deven McGraw, the Director of the Health Policy Project at the Center for Democracy and Technology. I'm going to make a few introductory comments to set the stage on why is consumer privacy and security so inextricably linked to the opportunities we have to remove health disparities. First, let me introduce myself. Prior to my role at Microsoft, I'm an attorney. In my early career, I did a lot of work on as a consultant to the Justice Department in health and justice community issues. I was a court monitor in a pretty broad health education and justice consent decree in Massachusetts. I became Secretary of Health and Human Services in Massachusetts for 3 administrations. And then left, did a little bit of work in a university, and then joined Microsoft as head of the health policy. So we've been talking a lot. One of the things that we've been doing over the last couple of years has been working with public leaders, private leaders, thought leaders, think tanks, and convening with them public and private innovation forums around the country. We've done them in San Diego and in Chicago and in Miami and here in the district. And one of the common themes that's coming up right now is the opportunity we have. And we believe that we're actually seeing the ingredients of a tipping point where we will see the real opportunity to improve health value, care quality, access, and outcomes. And that those opportunities come because there's a convergence of a number of different factors. We've had convergence of some in the past, but not all in the past. And those factors include the opportunity in the market disruption that is occurred in the context of health reform, where we have new care delivery models emerging. We'll have new healthcare financing models emerging. In addition to that, we've got technology innovation, and which I'll get to more in a moment, but the proliferation of mobile devices and cloud technologies and such a strong policy commitment and the rollout over the last couple of years and over the next number of years of electronic health records. And then finally, and probably key, an opportunity because of the previous points I've raised to get an engaged consumer in healthcare. I co-chaired a healthcare task force in Massachusetts a number of years back prior to health reform, and it was that issue of can you get the consumer engaged to help shape the marketplace, to help drive and demand accountability that has always been the question that has been perplexing. But we see a real opportunity for that now. Looking at how do we break down health disparities, I'll mention a few opportunities and challenges, and then from that, a few comments to set the stage for our speakers on privacy and security. Health reform. Briefly, just think of it this way again, and we've talked about this, but 30 million plus will receive coverage through Medicaid expansion and through the health insurance exchanges. New models of care and finance reform. On a technology adoption, as I referenced a moment ago. Significant movement in the curve to adopt electronic health records among our providers in the country. A rapid consumer and cloud technology adoption. Smartphone penetration in the U.S. has more than doubled to more than 50% of the public in just the past 3 years. It crosses all demographics, and it's important to think of this in the context, again, of health disparities. Those under the age of 30 and those who can't afford broadband are using mobile phones as their primary source of access to the internet. Consumer engagement. Why do we think more consumers are getting engaged? Well, the fact is, in the country right now, there are both market forces and policy forces setting the stage for consumers to become more active. On the market forces, citizens are paying more for their health care out of pocket, and it's having a pretty significant effect. So if you go into the business world, like our company, where as employees, people are paying more of a percentage of the cost of health care, that's getting them more involved, and it's proving that it's getting people a lot more actively tracking and engaging in what health services they leverage or choose to use. On the health policy side, the health insurance exchanges are just one example, but the whole design of health reform is to pull the consumer into choice and to become more of an active participant. And then we have care collaboration models that also flow from policy initiatives and finance reforms that are going to drive consumer activity as active participants in care collaboration models and healthy community models. As consumers become connected to friends and families and employers and to commerce and to social and health services, the barriers that prevent their access to care will begin to break down. Expanded access to minority and diverse populations. Just a few points on this. Newly insured under health reform, we're going to see a significant increase in the percentages of African American citizens, Hispanic-speaking citizens, unemployed, less healthy, less educated. This is important when we think of disparities, and it underscores what we've known, but we should continue to ponder this, that health disparities and removing them will be inextricably linked to also tackling education and economic opportunity. So in one of the previous panels where the deputy mayor of Newark was speaking, very important to look at those models that we see in Newark or that we're seeing in Live Well San Diego or Oklahoma City or Miami, where there's so much attention to the question of how are we going to raise the bar and raise the opportunity and access to services, and it'll be a holistic approach. 70% of minority and diverse populations, as Gary indicated earlier, live in 40% or 4,000 zip codes, or 12% of all zip codes in the country. So we have great opportunity to target how we tackle these problems. And a majority of them are served by approximately 500 minority-serving hospitals. So the last speaker at lunch, Dr. Siegel, the whole focus on the importance of the safety net hospitals in the community health system just jumps up at us. Some of the challenges and opportunities that we believe that we will begin to tackle through a combination of technology and consumer engagement and new models of care. One of them is the workforce shortage, and it's a very big deal. So we have, in addition to a primary care workforce shortage in the market now, over the next 20 years, there's going to be a mere 2% increase in primary care physicians, and yet a 52% increase in patients. Care coordination, as well as collaboration and communication technologies, can help to bridge the gap on that. So you'll see a lot more of collaboration tools and video conferencing, and even as we go out a year to 2 years, you're going to see more in the telehealth space, and you're going to see gaming technologies where in long-term care facilities or at home, elderly patients who are rehabilitating from orthopedic injuries will be able to do that with the support of their physicians and technologies in the community as opposed to institutions. On individual and population health, I won't go into this too into this, but I want to reference again the data that the National Minority Forum has been focusing on, and even how we can start to tackle some of the discussion that was framed at lunch in terms of lack of access and health disparities that relates to clinical trials. I applaud the presentations from Pharma today, as well as from NMQF, on this question of the ability to get down to zip codes, to look at those 500 hospitals, to look at the physicians treating minority and disparate populations, and to start to come up with a strategy where we can ensure the efficacy of treatment and access to treatments through a national clinical trial network. Very important in opportunities to strengthen core institutions and community networks. I would again, this involves the whole continuum of care providers, but I'd mention again the safety net hospitals. In many institutions, they may not yet have adopted the most sophisticated technologies, but they have a wealth of data, and there's real opportunity in terms of analytics, and for them to increasingly leverage their data so that it can form the community strategies and population health. Similarly, when we look at the Community Health Center Network, I suggest people consider the Health Choice Network out of Miami, which is doing school-based medical homes where they're identifying high-risk kids with high-risk health factors and working on education to health community strategies, working with groups like the General Electric Diabetes Foundation to target diabetes, and working with Gary and NMQF to leverage the diabetes index to target that. And then finally, in my final comments on engaging consumers, it's essential that we engender the trust of those who have faced a history of intractable health disparities. I just want to call attention to a couple facts here that are, if you think of them in context, it just gives you a sense of how significant this is as a point in time. At the same time, millions of minority and diverse citizens will obtain health coverage. They will also be adopting for the first time consumer technologies that connect them to the internet, web applications, and social media. This, in and of itself, presents tremendous opportunities to strengthen community connections. But it's incumbent upon all of us to recognize that they will also be entering a brave new world of social media, where communications they share with family, friends, and peers may in turn be widely distributed over the internet. And as new consumers who can choose health products and services, they will be widely marketed to. It's imperative on business, communities, educators, and technology industry to support them to navigate new modes of care and to the limitations regarding information that they choose to share over the internet. So we would argue this is a strong, and when we're looking around the country on community models, healthy community models, we have to really think this out in terms of how do we help people navigate and understand the limitations of the internet. In addition to that, however, in closing, I'd like to say that it's the time necessary for the information technology industry to stand up on behalf of consumers' privacy and security. Too often, compliance with laws such as HIPAA are seen as a ceiling for the industry's commitment to ensuring privacy. Laws and regulations are interpreted at times to give the broadest latitude to reuse information for advertising or other secondary purposes. The industry should consider compliance as a floor and not as a ceiling to its commitment to health information privacy. Individual patients and the insured have a valid and a justifiable expectation of trust that when their doctor or their clinic or their insurance company transmits, discloses, or stores their own personal data with an IT company, that company has a steadfast commitment not to use it or analyze it or mine it for any secondary commercial purposes such as marketing or creating an audience for advertisers. There should be a transparent commitment that the industry will protect and secure this data in a manner that we would want our own data to be protected. Now I have the pleasure of first introducing Leon and then Deven. Leon Rodriguez is the Director of the Office of Civil Rights for the Department of Health and Human Services. He was formerly the Chief of Staff and Deputy Assistant Attorney General for the Department of Justice Civil Rights Division. In addition to his private practice, Leon's prior experience includes serving as County Attorney for Montgomery County, Maryland, Assistant District Attorney in Brooklyn, New York. He served as Assistant U.S. Attorney and Trial Attorney in the criminal section of the Justice Department Civil Rights Division. He's a graduate of Boston University and Boston College Law School. And importantly, at this point in time, Leon is the top person at the top agency for the enforcement and protection of HIPAA privacy standards. Leon.
Good afternoon. So you might have noticed that I was the county attorney in Montgomery County. And that meant that I was, among other things, the lawyer for the political leadership in Montgomery County. And recently, I was at the post office, and I ran into one of the more opinionated council members in our county. And she said, "What are you doing now?" And I said, "I am the director of the Office for Civil Rights at the Department of Health and Human Services. And she said, "What's that?" And I said, "Well, among things that you would know about, we are the enforcers of HIPAA." And she said, "Well, that's terrible. That's horrible." And I said, well, why do you think that?" And she said, "Well, you guys are out there, you're putting the fear of God into people. You're frightening these doctors. And for what? What she asked me was, is the juice worth the squeeze?" And I wish that council member was here today, because the inclusion of a discussion about HIPAA in a discussion of health disparities is the answer to that council member's questions. Because if you are a person with mental illness, you will not seek care or you will not be forthcoming with your provider unless you trust that you have control over your health information, that your information is private and secure. If you're a person who is HIV positive, if you can't trust, and by the way, there are places in this country where you cannot trust, that your friends and family and community will find out about your condition when you are ready, then you may not go seek care. If you're a victim of domestic violence and you can't trust that your abuser will not find out that you went to the doctor and what you told the doctor, you may not get care for your injuries. You may not get care for your children because you can't trust. And so it is a civil rights issue. It is a health disparities issue to protect the privacy of health information. I'd like to tell you a little bit about the history of our agency. We are a civil rights agency. We were born in 1967 as a result of the Civil Rights Act of 1964. And many of you are familiar with the Civil Rights Act, and it talked about voting and it talked about housing. It also included a provision, Title VI, that prohibited discrimination in programs that receive federal funds. And back then, we were not just Health and Human Services, we were actually health, education, and welfare. And so the first thing we did as an agency was to enforce those many desegregation orders that were being issued by courts throughout the United States, in particular in the South. And the first, one of the very early directors of our office, of the Office for Civil Rights, was none other than recently retired Secretary of Defense Leon Panetta. He was actually the first director of our office under the Nixon administration. And Secretary Panetta, who was then about 30 years old, came to Health and Human Services. They gave him an office in the basement. That's where they had civil rights back then, was in the basement. I'm on the 5th floor now, so things have improved. And he started doing his job, which was to enforce those desegregation orders. There was a problem, though. The Nixon administration had a political strategy that some of you will remember and many of you have heard of, and it was called the Southern Strategy. And the main notion of the Southern Strategy was that desegregation had to happen slowly, incrementally. And we all know that justice delayed is justice denied, and Secretary Panetta knew that, and he set about enforcing those orders. And it wasn't long before he was told to begin writing his resignation letter. And he started writing that letter. Unfortunately, at least for the moment, his resignation was averted. But eventually, about 6 months later, he was fired because he was doing his job too well. So that is the agency. Those are our beginnings. That is our spirit, and that is the agency that is enforcing the HIPAA laws. And that is the agency that is here to talk about health disparities. And I see this as a great moment to celebrate some of the leaders that you have before you. And first and above all, Congresswoman Christensen. And one of the things that I've learned in this job is that the essence of leadership is identifying an issue, deciding that that issue matters, and then after that, convincing, working, cajoling, recruiting, manipulating, motivating until you get results. In doing it when nobody else has the vision, when nobody else knows that this is where we're going. And that's what Congresswoman Christensen has done in the area of health disparities. So my hats are off to her. And also a shout out to Gary Pruckrein for his leadership in the Quality Forum. It's only by this sort of collaboration, this sort of exchange of information, this sort of meeting of disciplines that we really are going to realize the dream of ending health disparities. Now let's talk a little bit about what HIPAA guarantees. And I'd like you to remember a concept here. HIPAA is a valve, not a blockage. Okay, there's a misconception that HIPAA makes healthcare providers unable to communicate, unable to do the things that benefit their patient. But that's not what HIPAA is about at all. HIPAA is about putting the patient first and putting the patient in charge of their health information and making the benefit of the patient the hallmark of how that information is utilized. So it's true enough, HIPAA does begin with a presumption that a patient's health information is meant to be private and secure, and that when it is disclosed, when it is used, it is for the benefit of the patient. It is either to provide that patient adequate health care or to run the operations of that physician's office. But within that, there are rules that, in fact, are common sense rules about how and when information needs to be shared. And so, first of all, one thing that often comes up is we were talking about that domestic violence victim. People need the support of their family, of their friends, when they go seek care. So, for example, that domestic violence victim that I talked about before, unless many times she will need a friend by her side, she will need her mother by her side, her sister by her side, in order to be able to get through her ordeal. And so the way HIPAA is set up is a common sense manner that says the provider, the physician, can make a judgment based on the circumstances and based on what the patient demonstrates to them and represents to them about who's going to hear their information. So it's perfectly appropriate for that physician to speak in front of that patient's friends and family members when the situation appears appropriate. At the same time, if a physician in fact detects that that same communication will harm the patient, whether it's her abuser who has next door, or it's a teenager who needs to communicate certain things to a patient that perhaps she doesn't want her parents to hear, then the physician is empowered to make a judgment in that case. Similarly, a patient can direct where they receive health information. So when a patient goes to a doctor's office, they have a right to tell that physician, I'd like you to call me on my cell phone. Please don't call me at home. I'd like you to call me at my friend's cell phone because I really can't be receiving calls on my own cell phone. And HIPAA also means access to your own record. And I had a really, and this is something that surprises people, because a lot of times there are actually providers who won't disclose a record because they say HIPAA tells them that they can't. Actually, the truth is HIPAA requires those providers to provide patients or anybody to whom a patient wants to direct that information to the patient. And so I was surprised when recently I was talking to members of my own staff, our administrative staff, and I told them about this. And a lot of them didn't know about it. That's how little known that right is by patients, that they could have access to their own healthcare information. And several of them said, wow, that's amazing because I actually need access to my healthcare information. Or I need access to my parents' healthcare information so I can help them be able to be real participants in their own healthcare. So these are some of the things that HIPAA means to consumers. Now, William made a very important point, and that is that we are in the midst of a dramatic transformation in health information, and one that will change the way all of us experience healthcare and the way all of us, there are so many providers in this room, the way we deliver care. And that is the utilization of the electronic health record and the personal health record. And these will really change the way information is transmitted, utilized, stored in healthcare. And I've often described when talking about the electronic health record, the role of the Office for Civil Rights as similar to that of the Securities and Exchange Commission in the securities industry. One of the reasons that people invest above all in the American stock market, it's not just the strength of the American economy, but it's because they trust that there is a watchdog who will ensure the integrity of that stock market. And so our role is the same with respect to health information, to ensure that people trust the integrity of their health information. And I want to share an interesting little point here. A lot of people fear that electronic health information is particularly vulnerable, that it is particularly at risk of being intruded upon, of being improperly disclosed. I remember last year I testified before a committee of the Senate, and one of the senators on the committee was actually himself a physician. And he raised his notes and he said, let's just say that this is a health record in my office. He said, the chances that this will be lost, that somebody will steal this, are nil, he said to me. And I said, Senator, I said, you might want to look at some of our press releases. You might want to look at the fact that one of our cases involved CVS leaving piles and piles and piles of health records in a dumpster. You might want to look at a very similar case that we had with Rite Aid. You might want to look at the fact that about a quarter of the breaches of which we receive notification are paper record breaches. And then we can talk about whether paper is more or less vulnerable than electronic health information. In fact, the vulnerability is about the same, and I'll explain why in a couple of moments. Nonetheless, there is that fear. There is that mistrust, and so our role is to ensure that that trust will exist. And we do it in a series of ways. First of all, I mentioned that we do breach notification. So now, any time that an entity that is covered under HIPAA experiences an inappropriate disclosure of health information, and that's health information that somebody can actually read or use. So it's not just any disclosure. For example, if you lose a laptop that's properly secured, you may not need to notify. But if the information is lost that is not properly secured, then notification needs to be made. It needs to be made to the affected patients. It needs to be made to my office so that we can review and investigate. And if it's a breach that involves greater than 500 people, it also needs to be made to the media, to the appropriate media that affects, that exists wherever the breach occurred. And so we use these breaches in several ways. First of all, we used the information that we received to analyze where the problems are, to be able to look at where we direct our enforcement efforts, where we direct our educational efforts. We also use it then to work with the entity that experienced the breach to fix the problem. One of the things that we require is that within 60 days, they identify the root causes of the breach, and they remedy those root causes. And to give you a sense of what are typically the root causes of those breaches are a failure to have done a proper inventory of where they have health information and what they're doing to make sure that that information is protected, and training their staffs to make sure they understand how to secure that information, and having disciplinary policies that promote the securing of that information. And so we've learned a lot of interesting things. One of the things that I mentioned is that about a quarter of the breaches are paper. The rest are vulnerabilities, very, very sort of ordinary vulnerabilities. Laptops that get stolen, personal BlackBerries and mobile devices that are either lost or stolen. Employees of the entity who, for a variety of reasons, improperly access the information. A relatively small percentage of the breaches are actually hacking. A very small percentage of them are actually the kinds of invasions that people actually fear. And so another interesting thing that we've learned is that if you look at it in terms of the number of records breached, a greater percentage of the breaches occur with contractors than with healthcare providers themselves. And so one of the things that's changed under the recent regulatory developments in those areas, that those contractors, we call them business associates, they are now regulated by us as well. And so we use a few other tools to make sure that information is secure. We use enforcement. And that's something that we've started doing for the first time in the last 2 or 3 years. We actually impose civil monetary penalties, some of them very stiff, in the millions of dollars, on entities that fail to take proper steps to secure health information. Now, we don't do that in most cases. In most cases, we work with the providers to fix what the problems are, to remedy the vulnerabilities. But when we find issues that show problems, deep problems, over an extended period of time, and especially in those cases where the entity does not take initiative to remedy those problems, we use our enforcement authority, and we're going to continue to do so. And we also are engaged in audit for the first time. And so the traditional way that we used to do business was that we would get complaints. A patient would not like the way their information was used, and they would come to us and make a complaint. And just through that alone, we were receiving close to 10,000 complaints a year. There's a problem, though. Patients can only see certain aspects of how their information may or may not be protected, may or may not be misused. So unless we are proactive, unless we go in and examine what's happening with that information, we're really not going to know where all the problems are. So we've started to do that. Last year we had a pilot audit. We audited 115 different entities. They included hospitals, doctors' offices, health plans, health clearinghouses, to look at where vulnerabilities are. And we learned some interesting things, and they're really going to form the foundation of a permanent audit program for my agency. So some of the vulnerabilities we saw, I talked before about the risk analysis, about reviewing where the vulnerabilities are and then taking steps to make sure that those vulnerabilities are minimized. And that was an issue we saw in many different kinds of entities, both large and small. We also saw a failure to use protective technology. And so one of the things that the privacy and security rules require is that there is an assumption that entities will use encryption to protect health information. And the provider either needs to use encryption or needs to demonstrate why they can't and employ an alternative that is just about as good. That's basically what the rules require. And in the audits, we found something interesting. There were entities that either used encryption or entities that did nothing at all. In other words, they did not research an alternative. They did not articulate why they did not use an alternative. And so that shows a real frontier in the area of protecting health information, that this needs to become a norm that healthcare providers either protect that data through encryption or they use other methods, other perhaps cheaper methods that are just as good. We believe that as entities start really thinking about it, as they start really considering what the best way to protect that information is, they will in fact use that encryption more and more. We've also, both through the audit and through some of our other work, learned that one of the real areas of challenge for us and for the health industry is with those smaller providers. And that's important to the discussion that we're having today. And so when we talk about big hospitals and big companies that have compliance officers and they have lots of lawyers and they have chief information officers, they have been able to make some progress, not complete progress, because we still hear from them a lot, in securing and protecting health information. Where there is an ongoing challenge is those single doctor's offices, those small practices of just a few physicians. And there we see continuing and very serious challenges to real compliance with the privacy and security rules. And so we've made a commitment to really work with those providers in education, in working with them to provide technical assistance. In fact, one of the steps that we took recently is to issue the mobile device security toolkit, which is specifically oriented toward those smaller providers, because William is 100% right. That is the future of how providers themselves are going to be utilizing health information, but as importantly, how consumers are going to communicate with their physicians, how they're going to access their information. So we've made it a real priority to talk about security for that kind of information. So I believe that with a strong commitment both to enforcement and investigations, the way I described before, but also to education and technical assistance of consumers, of providers, of contractors, that we will be able to validate the electronic health record, that we will be able to make sure that this is adopted and fulfills what its promise is to really make sure that patients can get the full benefit of all these new innovations in healthcare. I want to talk just for a quick moment about the rest of what we do in the Office for Civil Rights, because this issue of health disparities is something that really runs through the entirety of what we do in the Office for Civil Rights. We work on issues related to language access for persons who are limited English proficient. That's the largest part of our traditional Title VI work now. We work with persons with disabilities, ensuring that they receive language access, that they are not discriminated against by healthcare providers. And we also work on assisting individuals to transition out of institutions, those persons with disabilities, and being able to live in the community, which is another thing that's going to be made more possible by health information technology. So I really am appreciative of your time. I'm appreciative of this invitation. And I'm really looking forward to those questions and comments because those are important to me as we build our work and as we try to do the best job for America's consumers. Thank you.
Thank you, Leon. Could we go back to the, we're up there. Let me introduce Deven McGraw. Deven is the director of the Health Policy Project. The project is focused on developing and promoting workable privacy and security protections for electronic personal health information. She also serves on the Health Information Technology Policy Committee, and she co-chairs the Information Exchange Privacy and Security Work Groups. She serves on the Leadership Council of the eHealth Initiative. She's on the steering group of the Markle Foundation's Connecting for Health multi-stakeholder initiative. Actually, for me, it's a pleasure to have Deven here. When I was Secretary of Health in Massachusetts, she was working for then Attorney General Tom Riley, and our paths crossed a lot as we were really focusing pretty deeply on expanding health access and how we engaged providers and payers in that marketplace. Deven is a magna cum laude graduate of the Georgetown University Law Center. She received her Master's of Public Health from Johns Hopkins University. Deven, I don't know who has the switcher. If not, can you, they'll turn it for you.
Oh, they'll turn my slides. Okay. Oh, good. Well, that's going to be a challenge because I'm going to flip through a lot of these. So I'm, can I have my next slide, please? The work that I do is inherently what I call the work of being a consumer, oh, here it comes, and privacy advocate. But we take, I think, a slightly different approach to protecting privacy than other privacy advocates that I work with on a regular basis. We really strongly believe in the power of health information to be utilized to improve individual and population health. We cannot address the disparities issue without data. And so anything that we do on privacy has to appreciate the enormous gains that consumers and patients really should expect from all of this effort that we have underway and all of the taxpayer dollars that we are devoting to trying to improve the digitization of health data and to collect it and rely on it on a more consistent basis in order to inform care. Too often, I think, sometimes when we think about privacy, we think there's a mistrust about those data uses that forces us to adopt protections that often create obstacles. Most of them unintended, but they often create obstacles to the ability to use data for individual and population health purposes. But I also share the concerns of many people that the same data that can be collected and utilized for really good, important purposes can also be collected and used for purposes that people would not like. And that can impair trust in the system that we're really trying to build. So it's not an easy thing to think through what do we do about privacy and security that still enables us to be able to collect and use data in the way that we know we need to in order to improve healthcare for everyone, and yet at the same time create an environment that can be trusted. And it's an ongoing conversation that we have to have, and it's the reason why I'm really pleased that it's on the agenda at this conference. Because it's not a one-shot deal. It's not something that we can fix with one set of laws. It's going to be a continuing conversation that we will need to have again and again as we sort of think about the new opportunities that we have and what challenges they present for privacy and security. These first slides are the ones that I create for the audience that I'm trying to convince that this is an important issue, and I don't think I really need to do that here, in part because of the nature of this gathering, but also because my two predecessors did such a great job. We are not going to be able to build this system without building the trust of the public, and we know that when we don't do that, people practice privacy-protected behaviors like we're not going to get care, or trying to see multiple providers outside of their area so that their care is more dispersed, and therefore it's unlikely that somebody will put their whole picture together. Well, that's actually the very thing we're trying to fix, right, with electronic records, is to coordinate the care better from multiple places, and yet that's threatening to people who have high degrees of sensitivities about their data, and too frequently racial and ethnic minorities, persons of low income, trust less in what we're doing, which creates even more imperative that we do this right. Director Rodriguez is right. Paper's not safer. In fact, in many respects, we have tools of technology that we don't have in paper where we can do the job better. Role-based access, audit trails, being able to identity proof and authenticate users of an electronic record. You can't do that in paper. But at the same time, when something happens, a file of paper records doesn't have nearly as much data as the laptop, which usually has can have hundreds of thousands of patient records on it. So, and for a while there, I thought that we were in sort of the year of the lost laptop or the stolen laptop, right? It felt like every other day somebody's laptop with patient data was being stolen out of the back of somebody's car or left somewhere, and that's a problem both for the patients whose data is on that laptop. It's also a problem for this trust building endeavor that we're all trying to be engaged in. It just deepens people's mistrust. They think, well, those people don't know what they're doing. Why would I trust them with my data? That's certainly an environment that we want to fix. And so we need to think about privacy and security as the enabler to all of the goals we're trying to achieve with health data. And the way to do that is to build on the laws we already have. HIPAA is a great way to start, but as Bill pointed out, it's a floor. We need more. Some states have acted to do more, but we also need policies and practice, what we call little p policies, the way that businesses operate on a day-to-day basis to continue to build that trust framework. And HIPAA doesn't protect all health data. Director Rodriguez has some great enforcement tools now in his toolbox, but he has a limited number. He can't get everybody who collects health data. The commercial space is still largely regulated by the commitments that companies make in privacy policies that frequently people either can't read or don't fully understand. And that's sort of a pretty slim foundation for trying to build a greater ecosystem where we're encouraging patients to use self-management tools such as applications on your phone or social networking sites, all of which can provide enormous benefit. This should not be a scary place that we're leading consumers into and encouraging them to use, but we've left out a piece of that, and that includes making sure that there are comprehensive privacy protections for that data as well. Recently, the Office for Civil Rights issued a final rule to implement some improvements to HIPAA that were mandated by Congress in the stimulus legislation of 2009. And there are a number of big wins for patients in these rules. I mean, the biggest win of all is that we have the rules, which took some time to come out. But nevertheless, there are really some big things in here that are worth noting. And I won't go into too much detail on them because that's really the kind of privacy detail that makes you the last person people want to talk to at cocktail parties. But the standard for when patients have the right to be notified in the event of a breach is changed. It's not tied to whether that data would harm you. It's more of an overarching assessment of what happened to that data, who likely got their hands on it, what's the likelihood that anybody got their hands on it, and a more complete sort of analysis of what happened and a presumption that unless there's a low probability that that data was compromised, then the individual needs to be notified, and so do the regulators. As Director Rodriguez noted, there is an extension of accountability now to really down the health data chain, right? So not just for the immediate entities that are covered by HIPAA, the doctors, the hospitals, and health plans, but their contractors, and their contractors' contractors, and their contractors' contractors' contractors, and so on. That's really important because HIPAA does have limited scope. I mean, that's by design by the design of the statute. But the Office for Civil Rights and Rulemaking has taken it about as far as one could, and that's a good thing because it does extend those protections to a greater number of data holders. Strengthened protections for use of your individual health information for marketing. This was a huge one. Marketing is one of those things that just really digs at people, especially when they find out or think that somebody knows about their health information and is trying to market something to them, right? It's one thing to get a notice about a prescription drug that you're already on, like something that reminds you to take something that you already know you're supposed to be taking anyway. That's helpful. But something that you get where they're telling you they want you to switch to something else or they want you to try something else, and you're wondering, how the heck did they get information about what drug I was on? This shows up in survey data as being something that drives people crazy. Well, those marketing rules, thanks both to Congress and the regulators, were strengthened. And now, if the product manufacturer has paid for that communication to be sent to you, and it's a communication that used your health data to send it to you, it's marketing. And under HIPAA, marketing requires your prior authorization before your data can be used for it. There is an exception for drugs and biologics that you're already on, again, under the public policy exception that we want you to get communications about drugs that you're already taking. But for new things, something that looks like an ad and was built using your health information, you have the right to authorize that first. And that, to me, is just a really important trust-building aspect of HIPAA. There's some other pieces in the new rule that sort of recognize how important it is for people to be able to get and share their own health data. The ability to get your child's immunization records and have them sent to school and not have to fill out necessarily a written authorization for that. If you can just tell the nurse at the desk, yeah, go ahead and send it to the school and it can go. How wonderful is that? Just a really important clarification, and what a huge relief for parents. The ability to find out if there's someone in your family has been deceased and this is someone that you participated in their care, to find out more about their health information. Again, absent that, I mean, they're the patient, they hold the privacy rights, but if they haven't said to their doctor, oh, don't share this with my family member, then the presumption should be that, in fact, that you can get that information too. And for many inherited disorders, this is going to be incredibly important. So the clarifications there are absolutely critical. The right of patients to get health data, that was part of HIPAA from the very beginning and still is and has been strengthened. You have the right to get that data electronically. I will say, since I'm on the podium, an outer deadline of 30 days or even 60 days is way too long, and I understand the reason why the rule is set where it is, because for any given patient's request for information, that data might be in a warehouse somewhere far away and hard to get to. But at the same time, when we're using the meaningful use program in the next stage to sort of push people to be able to get data and to be able to access online their health information, their lab test results, the lab test results of their family members within a day, within 2 days, to really create this sort of data liquidity that empowers patients, that gives them the capacity to be partners, to be drivers of their own healthcare bus, to be real partners in care. You can't tell them, well, we can't give you this data for another 30 days. And so I think while I understand why the rule is where it is, I think we still have some work to do on that, and I hope we will. The other win for patients that I want to point out to you is one that might surprise you a little bit, and I actually had a HIPAA lawyer that I know really well, she actually went to law school with her, tell me she thought this was a security loophole of all time. So ordinarily, if you have electronic identifiable health information and you're covered by HIPAA, you are supposed to transmit information in a secure way. I mean, Director Rodriguez pointed out, it should be encrypted. And if you're not going to use encryption, you really have to choose a secure mechanism in the alternative. You can't just sort of nakedly exchange data without any security protections whatsoever, particularly when it's in an electronic form. But patients have an absolute right to their health information. And while ideally we also want patients to be able to have data sent to them in a secure way, if the patient finds it more convenient to use a technology that's not secure, like their unsecure email that they use every day to communicate with their friends, to send business emails, if that's more convenient for them and that provides them with the kind of instantaneous access and they want it in that format, then why can't they get it in that format? And what I love about this omnibus rule is it says, well, you know what, they can get it in that format if that's the format they want. And it's a good idea for the provider to say, well, are you sure it's not secure? We can work something out to get this to you securely, or we have a technology, ideally, I think they're supposed to, have a technology to get this to you securely, but if you don't want it in that format, I will give this to you because you have the right to get it in the form or format that you want, as long as I'm capable of producing it in that way. And again, my friend said, isn't this a big loophole? And I said, no, because it's essentially responding to it's the patient's data. And it's responding to their needs to get the data in the form or the format that they want. You're not asking them to forego an opportunity to get it securely. They can still get it securely. But if it's better for them to get it in another way, why can't we honor that? We know from watching the way kids use Facebook and other technologies and texting that some people have very low privacy thresholds. Maybe they shouldn't, but many do. And we need to sort of meet people where they are if we have expectations for them to use data in a liquid way. The increased enforcement that we have seen in the last few years under Director Rodriguez's leadership has been incredibly important. I mean, for years and years and years, HIPAA was the right without a remedy, because all HIPAA violations were treated as opportunities to counsel entities about how to come into compliance with the law. And that's a fine approach when legislation and regulations are new, but it's not fine 5, 6, 7 years after the fact when we're trying to build this trust environment. And that's why the enforcement efforts, particularly aimed at some of the worst offenders, if you read through the settlements, this is, these are not small potatoes violations here. This is pretty much failure to comply with what's been a legal obligation for quite some time. Having said that, as is always the case, when there are increased penalties for violations and an increased enforcement environment, sometimes that makes, people retreat into their shells and say, well, the path of least resistance, my way to not be liable is not to share data at all. And you don't have the option as a covered entity under HIPAA to not share data with patients. You have to give it to them, and you have to give it to the government too when they ask for it. But you don't actually have to share it with your peers with your other healthcare providers who are providing care for that patient. And so, frequently I have heard actually from healthcare providers who have said, well, I tried to get the patient's record, but they told me that HIPAA wouldn't give this to them. And I just wanted to scream. But the reality is that HIPAA says you can share for treatment purposes with other providers. And you can share in order to be paid. But it doesn't say you must share with other healthcare providers. And there are good reasons for that, but that creates a little bit of a problem for us, because if you think it's risky at all to share and you don't have to share, then what's the likelihood that you will? And so that's one of the reasons why I think it's important that the greater enforcement environment that we have also be paired up with more and more guidance. And we're getting some great guidance out of the Office for Civil Rights lately. I wish it didn't take quite so long to come out. I know that's not entirely the fault of the people on the dais here. So I'm going to continue my push for more guidance on, that has specific examples about what you can do and what you should do, so that providers don't, no longer have an issue with facing the potential penalties on the one hand and knowing that they want to share but uncertainty about whether they can or not. Let's clear that up. Guidance, see priorities for the near future. Guidance. Protections for health data when collected and shared by entities not covered by HIPAA. Again, we got some good reports from the White House and the Federal Trade Commission in 2012 about protecting consumer privacy, both online and offline. And yet, we really haven't seen a lot of action beyond that. And I think we need to accept the very real, the environment we have now, and the one that we're trying to encourage, where we actually want consumers to be active collectors and users of their health data using tools, again, like mobile apps and social media network sites. And so we do need some baseline protections for them. And that's one of the things that we work on at CDT. And then finally, we do need frameworks for the ability to use data that we're collecting initially as part of a clinical treatment encounter, so that we can learn more about how to improve healthcare quality overall and to reduce disparities. We started this conversation about the importance of data, right? Well, the rules about how you can reuse data for quality improvement purposes and for research purposes are not very well understood. And research is happening in spite of it, but it's not easy. Talk to a researcher and they will tell you it takes months and months and months and months in order to secure the necessary approvals in order to move forward with an initiative to analyze data. And this is one where we have to be very careful to get the privacy issues right, while also making sure that we've created a framework for the reuse of that data. So lots more work to do, work that I would love to work with the National Minority Quality Forum on, because I think it's important. It's important, to the populations that you serve, that we get this right, and I look forward to it. Thank you.
Thanks, Deven. Well, we have a few minutes for questions for Director Rodriguez and Deven. So, yes, over here.
To Director Rodriguez and Director McGraw, I think all this information is very important for us physicians in private practice. More or less 40% of the physicians in the United States across the country are in private practice, and to know all these things that you presented today is very important. I don't see that many of my colleagues from the area of the country where I come from. I think information for us is important because we need that information to treat our patients. And it's very important to have immediate access. For instance, when I'm an ophthalmologist, when I'm seeing a patient with optic nerve edema, to know exactly what is the result of the MRI. I need to get access, and I do that through my computer system from the last examinations done at the hospital. At the same time, when I have a patient, I'm thinking about a patient that I have this morning with Wegener's granulomatosis, where the wall of the eye is melting down, and I need to coordinate the treatment of my patient with the rheumatologist and the oncologist who's given infusions of different medications. I need to have immediate access to the physicians and to the information. I don't have electronic medical records in my office, and this is something I want to comment with you, is because it's very expensive. And I would like you, people in the position in which you are, to address this issue with us physicians, directly with us, and see how can this be solved, and how can we implement electronic medical records in a way that is cost-effective, and it certainly help us to take better care of our patients. In terms of protection, we always consider the information of the patient sacred, and we only share it when we need, for medical reasons, to share the information with other physicians, without hesitation, I would say. Thank you very much.
Thank you. Would you like to comment? Your microphone. You're mic'd if you want to.
Yeah.
Okay, just stay right where I am.
Yeah.
Okay. So I think the expenses of adopting the electronic health record is a very real issue, and that's why the initiative was taken for the government to give the meaningful use grants that many physicians have taken advantage of. I think one of the things that I think that I would imagine we'll see happening, it's like, you remember in the old days, the new TV would be $1,000, and many years later it would be $200, $150. I think as the technology becomes more widely adopted, more simplified, it will become more accessible. I also think we're going to reach a point where there's going to be no choice but to use it, because it's going to become the norm of what people do. We're certainly very conscious of the plight of exactly the physicians that you're talking about, because it's an issue for us in terms of compliance with the rules that we enforce. And where, for example, we've been dedicating a lot of our educational tools. We have a series of Medscape videos that are out that I recommend to all of your attention, including one that we just actually did with a practicing obstetrician gynecologist that really talks practically about how you implement the privacy and security rules in a physician's office. But we do recognize that those challenges exist. I don't know if there's anything Deven
Yeah, I mean,
like
I would, the drive for cheaper models we're already starting to see it. With some of the sort of lighter weight software as a service type of electronic medical record arrangements. Those are not the only ones, but the financial incentives that were part of the HITECH Act were really important sort of kickstart to enabling the adoption of electronic medical records, but they're diminishing in their amount, and they didn't cover even all healthcare providers. Some were not included, including long-term care providers, and they weren't the only ones. But we are starting to see some cheaper models, and there are cheaper models that also have been granted certification, and you have to be using certified technology in order to receive credit. Weren't the Stark and Fraud and Abuse rules also recently extended? So the exemption, so that if a hospital supports the provision of technology by the physicians on the medical staff, they can do that, and it's not a Stark or a Fraud and Abuse Act violation as long as they meet certain criteria. So things are loosening up. It's never gonna completely cover the high costs of adopting these technologies that exist today, because it's not just the cost of the hardware and the software, it's the cost in lost workflow, the amount of time it takes to get used to using these systems. And so in many ways, the more that we can start to value, the better, and pay, and really pay for the types of interactions that are facilitated by the technology in ways that we don't today, I think that will help too. It's sort of a partial answer. It's not the greatest answer. I wish there were more that we could do, frankly, and especially for safety net providers for whom this expense is just astronomical.
Thank you very much.
We can take one more question.
I thought I saw they extended that.
Good afternoon. Thank you so much for the two excellent presentations. I'm Dr. Ho Tran from the National Council of Asian Pacific Islander Physicians, and two comments I would like to make. First is about your presentation about, with the health insurance exchange, there'll be an increase of minority population being insured. So we do have, we have an increased number of the Asian, Native Hawaiian Pacific Islanders population as well, which was not on your that. So it means that, the comment about your presentation, Ms. Deven, it is about, accessing the records, And so we do have a problem, within our own physicians, serving the minority population, that are accessing in which language. because our population don't speak, kind of, they do have like, Mr. Rodriguez was saying that the low English proficient perspective. So it creates a lot of anxiety among our physicians because it is the law, they will be penalized, but accessing English language first. Second, that about your point about that as soon as possible, which I agree that it is the best, but it is we talk about a population of patients who can speak English well, who understand the numbers of that. So we did a survey among our physicians, among the AAPI Asian population, and they are struggling because it will need some time for them to translate what they write on their notes, and because that they don't want to be penalized in the future when the patient access the record. So sometimes they take it home, and so that's how the delay in having that report as well. So kind of comments like that to help you look at the ground level how it will impact on the way that physicians practice as well.
Thank you.
Thank you for your comments. Appreciate them.
Well, I know we're running into the next presentation. I wanted to, actually first I wanted to thank the National Minority Quality Forum, as the other speakers have as well. This is a topic that couldn't be more timely, as we've said, from two perspectives: the importance of engaging and keeping a consumer engaged, particularly to reduce health disparities. And you can't have any topic that's more important to accomplish that than to make sure that we're dealing with privacy and security of their information. So join me, if you would, in giving an applause to Director Rodriguez and to Deven as well. Thank you.